Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren, the executive editor of MedEvidence. And we're going to do something a little bit different today. And this came out of a meeting, actually a business meeting, with my friend and colleague here, Tucker, who just started running his cholesterol results by me. It was funny. It has nothing to do with medicine, but he knew that I was a cardiologist and he knew that I'm very active in the lipid field. And he started asking me questions about his personal circumstances. And it got me thinking, an intelligent guy like Tucker, who's truly interested in his health and doing the best for himself and his family, had these questions, and it brought up some misconceptions that people have, and also the fact that there's a lot of information out there that sometimes is tricky to discern. So Tucker, welcome to MedEvidence, and tell everybody a little bit about yourself and why you got a series of cholesterol and other tests that may be of interest to everybody.
Yeah, absolutely. And thanks for having me here, Dr. Koren. And happy just to have this conversation and really educate myself and others that are in the same shoes as I, that, really care about their health, but want to go the next step or go a little further in their journey and making sure that they're doing the best they can for not just themselves, but their family. I have a unique family story. I lost my father to a stroke, heart attack, and it really put in perspective how
old was he when he passed?
He was 56, I want to say. The stroke happened and then progressively got worse over time. So it was in 2008 that he had a stroke, and it really just opened up my eyes for my health journey, and now being a father of 3 kids, 3 boys, and wanting to be a grandfather one day and see them live out their lives as well.
How old are your kids now?
So I have a 6-year-old, a 4-year-old, and a 1-year-old.
It's a busy household, my friend.
It is. It is indeed. It is. Hearts are full and hands are full, for sure.
Absolutely. So you mentioned about your dad. Any other members of your family die of a heart attack or stroke, say, before the age of 60?
No.
Okay.
No. My mother's mom had passed away from cancer, but not of any heart issues.
And are you having any specific symptoms that make you worry about a heart attack or a stroke?
No, honestly, no, nothing in particular. Just wanting to be more educated.
Great. And I'm just going to ask you some basic questions that a cardiologist would ask a patient. If any of these are not understandable or you ask me why I'm asking them, that's fine. Please ask me. But we usually ask people about a series of cardiovascular risk factors because we're trying to get a sense for what your actual risk is and whether or not your history is more or less likely to reproduce your father's history in terms of having a major cardiovascular event at a relatively young age. So with that in mind, the things we'd ask is, 1, do you smoke?
No.
Never smoked?
No smoke. I've smoked a cigarette before, but not consistently smoked, right?
Okay, gotcha. Yeah, it's funny. The definition of somebody that may have smoked is 100 cigarettes in your life. Yeah, although, quite frankly, most people in college will get to that number just going to bars on the weekend.
Right, exactly.
But you never smoked habitually on a regular basis.
No.
Any history of diabetes?
No.
Okay. Do you have high blood pressure? Are you being treated for high blood pressure?
I have high blood pressure. I'm not being treated for it. It's not to the point where I feel it, needed to be treated for. But yes, I'd say I have the white coat syndrome. Every time I get it tested, there is.
Give me a range for what that blood pressure is when it's at its high and when it's at its low.
I have no idea,
Okay.
to be completely honest with you, because it's, they'll come back and take it and they'll be like, you're fine. So
has anybody told you your top number, your systolic blood pressure is more than 160?
No.
Okay. Has anybody told you that your bottom number, your diastolic blood pressure, is more than 90?
No.
Okay.
No.
Have you been told that your blood pressure actually did in fact normalize when you're outside of the doctor's setting?
Yes.
Okay.
Yeah.
So what you know about your blood pressure is that when you're stressed, it may go up a little bit, but other times it's normal, which, by the way, is a normal thing.
Right.
Blood pressure naturally goes up when you're exercising, et cetera. So getting back to the cardiovascular risk factors, I understand you do exercise regularly. You look very fit.
I try. Yes, I try.
Tell us about your exercise routine.
Yeah, so I typically 4 to 5 times a week, more on the 5 times. And it's a mixture of, weightlifting to higher heart rate cardio HIIT stuff. So, a good combination of weightlifting and high heart rate.
Nice. And never get any kind of cardiovascular symptoms like chest pain or tightness or breathing issues while you're doing your exercise?
No.
Fabulous. Now, there's some cardiovascular risk factors that are obvious. Being a male puts you at higher risk than a female. You're a male. And your age, you want to state your age for everybody?
35.
Okay, so you're a young man, so that actually puts you in a lower risk group. And by the way, age of all the standard cardiovascular risk factors is the one most predictive of who's going to have trouble. So even if everything is perfect at age 80 in terms of your cholesterol and your blood pressure and your sugar status, your risk is still higher than somebody at 35 that has a lot of problems with these numbers. So I always like to bring that into perspective, that age is the most predictive thing that we have, which is actually sobering for doctors, is that quite frankly, if you know somebody's age, you're going to know more about their prognosis over the next 10 years than anything else. But that's a little bit different than what you're here for. You're here to maximize the likelihood of a good outcome for yourself over the next 10 years. And then when you're 45, you're going to come back and say, I want to maximize that likelihood for the next 10 years, et cetera. So while age is the most potent cardiovascular risk factor, there's a relative concept here, is that you want to reduce your relative risk at your age. Is that a fair statement?
That is very accurate.
Okay.
Yes.
All right. So now we're going to jump into it a little bit more.
Sure.
You mentioned that you did go online because of your concerns about your family history, and that you got some extensive lab testing. So just tell us a little bit about that story.
Yeah, it's always something that, like you had said, given family history, that I've wanted to do, and this was very user friendly. The platform that I used to gather all this data, and went to my wife, and she wanted to do it as well, and the numbers were that.
And we'll go through some of the numbers, right? But you got a lot of data. Did you feel like you understood everything, or did it? Tell me a little bit about that.
No, and that's one of the conversations, or what led me to you in our business meeting, and saying, Dr. Koren, can you please look at this and break this down for me, because I have it, I don't know what to do with it.
Got it.
And that's why we're here today.
Sounds great. Okay. Well, if it's okay with you, we're going to just kind of jump right into stuff.
Absolutely.
And you and I can look at the numbers, and people in the audience, either the viewers or listeners, can get this information. You give us permission to show this online?
Yes, sir.
You okay with that?
Oh, yeah.
Okay.
Yeah, that's why we're here.
Okay. Well, we'll cross out your name so they can't see that other than Tucker. But this is the old HIPAA thing. We want to make sure that your privacy is protected.
Yes.
Obviously, coming on this program shows that you're okay being out there a little bit, but we still want to protect your privacy as much as possible.
My goal is to help others.
Terrific. So starting with your cholesterol profile, we call this lipid profile, quote, standard, which literally millions and millions and millions of people get every year. And I have family members and friends, et cetera, that are constantly calling me and, what does this all mean? And typically in this lipid panel, you see total cholesterol, HDL cholesterol, triglycerides, and LDL cholesterol. And then below that, you have the ratio, which is the proportion of things, cholesterol to the HDL, and the non-HDL cholesterol total number. So does that make sense to you? When you look at this, do you have an intrinsic a sense of, I know what's going on, or not so much?
I know I have some things out of range, and some things I need to work on, but aside from that, my knowledge is very, very low about this. Yeah.
So let's just start with a basic concept, which is the difference between total cholesterol and LDL. Cholesterol is a lipid. It's a fat molecule. Cholesterol is actually a really, really important molecule in our bodies. Every cell in our body needs cholesterol to function. And because cholesterol is so important to cellular function, every cell in our body makes cholesterol from basic materials. So our cells make cholesterol. This is the thing that most people don't understand, which is that because the cells are making cholesterol and pushing it out when there's extra, by and large, what we measure in the bloodstream is the extra stuff our body's trying to get rid of. So there's a big misconception, even amongst some physicians, that somehow we need dietary sources of cholesterol to function and have normal lives. Well, cholesterol is actually a product of animal cells. So if you're a vegetarian, you're not going to eat a lot of cholesterol in your diet.
Right.
but that's okay because your body makes it.
Right.
But vegetarians can still have a high level of cholesterol in their circulation because of genetic factors. So again, think about cholesterol as something that all your cells need, all your cells can make, and the stuff that you're measuring in the bloodstream is the extra stuff. But as I mentioned, cholesterol is also a fat, and your blood is mostly aqueous or water-based. Do fats and waters mix? Do you ever put fats in a cup of water?
It's like oil and water.
Exactly.
Yeah.
They don't mix.
Right.
So how do you get this to move in your circulation and eventually get out of your bloodstream? Well, the way you do that is by forming lipoproteins. Your body forms lipoproteins, and we'll show a picture of that. But lipoproteins are these much larger molecules, typically shown as spherical molecules, that have a combination of fat and protein, which can be soluble in the blood and then eventually get delivered to different places, most commonly the liver, to get rid of them.
Interesting.
So HDL and LDL are two, quote, lipoproteins. High-density lipoprotein and low-density lipoprotein.
Understood.
High-density lipoprotein is epidemiologically linked with better outcomes, meaning that if you have higher levels of HDL, you're less likely to have cardiovascular disease. LDL is the opposite. If you have high levels of LDL, you're more likely to have bad cardiovascular outcomes. Now, because of this epidemiological association, we talk about HDL as the good cholesterol, quote unquote, even though it's more than just cholesterol. And we talk about LDL as the bad cholesterol, even though it's more than just bad cholesterol. And more recently, there's another particle that's become something we talk a lot about, which is called lipoprotein little a, which we like to say here at MedEvidence is the really, 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 really bad cholesterol.
Right.
4 really bads. and the reason for that, and we'll show it structurally, is it has an extra little component to it called an apolipoprotein that makes that particular particle more difficult to get rid of, to get out of your bloodstream. And because of that, there's a much stronger epidemiological link between high LPA and bad cardiovascular outcomes. And I mention this because you may have a little bit of an LPA problem here.
Right.
We'll get to that.
And that's something I can control or not control?
Well, we'll get to that.
Okay, gotcha.
We're going to get to
I'm
that.
jumping the gun.
We're going to get to that. But I just want to give everybody the basics, because even simple things like this, I find most people don't really understand exactly what they are.
Right.
But does it all make sense so far?
It does. Yeah.
Okay.
No, it helps a lot.
And then finally, you have another type of blood fat called triglycerides, which is really about energy. Triglycerides are one of the energy stores for your body, and it's actually needed for energy. But it's different than cholesterol, which is also structural. So cholesterol is the foundation of hormones. Cholesterol is the foundation of cellular walls of the cells. But triglycerides is really an energy store. Okay. So we have all those things here, and you'll be able to see it from the audience that Tucker's total cholesterol is 261, which is a little bit high, and it's listed as the reference range is less than 200 milligrams per deciliter. But again, we're going to talk about the fact that if that cholesterol is in HDL, it's not as bad as if it's in LDL. And moving down, your HDL is 67, which is actually pretty good. They're saying the reference range is above 40, above 60 is even better. So that's a positive. You have a high HDL, probably in part due to the fact that you're physically active. Physical activity in exercise, particularly intense exercise, will raise your HDL. Another thing that can raise HDL, I didn't ask you about this yet, is alcohol use. What's your typical alcohol use?
Yeah, I would say weekly, I guess you could base it off of, probably 4 cocktails a week.
Okay.
Or 4 alcoholic beverages.
So you don't drink every night?
No.
Okay. So you go out for dinner on the weekend and a glass of wine. Okay. So
Right.
4 alcoholic beverages per week. So that's not a big driver, but that's certainly not something that I would consider unhealthy from a heart standpoint. There's some debate about whether or not alcohol use at moderate to low levels may have some negative effects on your GI tract and GI systems, but from a cardiovascular standpoint, I'm perfectly okay with that.
Yeah. And there was a time that it was a lot higher than that. I'll preface the audience with that, and since doing, these panels and really dialing in, where I want to be, I've been cognizant of intake.
Yeah, and the other thing, by the way, is when you drink a lot of alcohol, your triglycerides may go up. That's one of the things that can drive higher triglyceride levels. And yours turn out to be very normal, 73. They say that for the reference range that it should be less than 150, but in fact, I love seeing them less than 100. So you get a fist pump for that.
Love it.
So your triglycerides, you're kicking butt onto the triglycerides.
Good.
But this is a little concerning. Your LDL is 177.
Right.
Okay. And they don't even give a reference range from that. And they also put something interesting in it that says calculated, which I like to make sure people understand, is that LDL, for most of the assays that are done, is not directly measured, but is actually calculated based on your total cholesterol, HDL, and triglycerides. And for somebody like you that has numbers kind of in mid-range, that's not a big problem. It's usually pretty accurate calculation. But if you have particularly high triglycerides or a low LDL that you're trying to get really low, for example, patients of mine that have very bad cardiovascular disease, that calculated measurement may not be as accurate as a direct measurement.
And you can get a direct measurement?
You can get a direct measurement. It's a little more expensive, and doctors have to ask for it specifically, but it is obtainable. I'm not going to go into all the different ways of calculating LDL, but I assume this is what we call the Friedewald equation, which is the most commonly used way of calculating your LDL.
You're exactly right. It says,
And that would typically be the total cholesterol minus the HDL minus the triglycerides divided by 5. So you can check to see if their math is correct now that I give you the formula.
Great. Thank you. I will.
All right. And then moving down, you have your cholesterol to HDL ratio at 3.9. They say less than 5 is what you want to see. And that's in part because you have a nice HDL cholesterol. And then your non-HDL cholesterol, which is all the stuff other than HDL, is 194, which again is high. So just looking at this, we would say that this lipid profile is not exactly where we would want it. And the first question that comes up is, what's going on with your diet? Are you eating a lot of meat? Are you eating a lot of saturated fats? As I mentioned, your body can make cholesterol, but your dietary sources of fats and cholesterol also drive this. And remember, it's not just cholesterol when you're consuming, but fats. In fact, saturated fats are more likely to drive higher cholesterol than ingesting cholesterol itself.
Right.
So tell us a little bit about that part of your life.
Yeah, I do eat a lot of red meat and meat in general, I guess you could say, as far as chicken, and I try to stay away from pork. My fish intake is lower than what it probably should be, in my opinion. So primarily every meal it's either chicken or steak. Now that I've gotten these results, I've kind of gone more to chicken, but yes, and then dairy too, right? And cheeses and eggs and different things like that. But pretty bland for the most part. I do have some rice mixed in or some grains mixed in, but that is something I try to be cognizant of, and then work in some fasting as well, just to help cellular repair. Would
you say that you eat meat during every meal during your day?
I wouldn't say every. I would say 1 to 2 times a day.
Okay.
So leave out breakfast and just have the dairy as far as or eggs and then probably lunch and dinner. Yeah, that's a fair assessment.
Yeah. So obviously, bringing that meat consumption and dairy consumption and egg yolk consumption, obviously the whites of the egg don't have cholesterol in it, but the yolk does. That would help drive down your LDL. But the truth is that, as I mentioned, because so much of cholesterol may come from your body itself, it's very variable how much reduction in LDL cholesterol you get when you change your diet. And I've had people that have changed to vegetarian diets or even vegan diets, and they have a dramatic lowering, but other people that do it and they are very disappointed that they don't have more of a lowering. And that tells me that their bodies are intrinsically making cholesterol that's being put into the circulation. But the truth is, it's very hard to know that without having a patient try it. So often we'll take somebody like you and say, okay, well, you're a young guy, you're not having any symptoms, you have a cholesterol profile that's a mixed bag, good HDL, but not great LDL. And maybe you should go on a much stricter diet where maybe you eat red meat once a week. Maybe you eat fish 5 or 7 times a week, which I tend to do. My main protein in my diet would be fish.
Okay.
And try to cut back on the cheese, and maybe instead of doing regular omelets, do egg white omelets. Right. And put these things into your diet, and then recheck in a few months and see if you put a dent in that.
I was going to say, how long is it typically that you would have to do that trial, so to speak, to see results?
Typically, you want to see about 2 or 3 months.
Okay.
That's usually what what you want to see. For triglycerides, by the way, if you have high triglycerides and you change your diet, that'll change very quickly.
Okay.
But the LDL may take a little bit longer before you're going to have an impact on it. And again, nutritional elements of this are a whole podcast in of itself, because there's a lot of nuance in all these things. But as I mentioned, saturated fats and the ingestion of cholesterol will drive this, will drive your LDL levels up. But saturated fats even more than cholesterol. And the reason I bring that piece up is that shellfish often becomes a discussion. Shellfish is high in cholesterol, but very low in saturated fat. So that's not a bad place to go if you need to replace certain things.
So shrimp aren't bad.
They're not as bad as really fatty meats or eating the skin of chicken even. But I personally will eat shellfish, and I consider that part of my diet that pulls out from the meats and the fats and is using a lower fat, but something that's not super low in cholesterol.
Good to know.
Okay, so hopefully that makes sense. So getting back to these type of interventions, the other thing is that there are certain foods like oatmeal, for example, that make it more difficult for your gut to absorb cholesterol. And if that's not in your diet, you may want to think about things like that. So grains and other things that we often eat in the mornings, but not necessarily, are important. And also bananas, other things that have roughage, etc., are good things for us to consider in terms of diet. And again, this is not an extensive podcast on that. But there's lists online where you can see how all these different foods can actually affect cholesterol absorption and their glycemic index, which is a whole nother conversation.
Is there a way, let's say you do go through with a meal plan for 3 to 6 months, do you notice any difference in your body as far as if your cholesterol levels change as far as energy or anything like that? Or is that strictly felt off of or captured off of a blood test only?
Well, it's interesting. It is different for different people, but there's no doubt that the type of food you eat does affect your mood. It affects neurohormones that affect your brain. It affects your appetite. So there's a lot of factors that go in, and everybody's not exactly the same. So in general, when you eat high protein things, people feel a little bit brighter. When you eat some things that are high in sugar, sometimes that raises certain hormonal levels that make you feel sluggish. Although other people have an immediate rush when they have sugar. So again, these are competing hormonal levels. I'll tell you for myself, if I have something that's very, very sweet, I want to take a nap in 15 minutes. Whereas other people kind of get that sugar rush from it. But these are how different hormones are balanced in your bloodstream and how they affect you. So there's no doubt that foods affect your mood and affect your function, but it gets very individual. And we'll definitely look at that for a future podcast about some of those details. But do you have any observations for yourself when you eat high protein versus low protein?
No, honestly not. I mean, I do. It's more the fasting versus not fasting for me, really. I notice energy levels and whatnot when I haven't eaten and I've done a moderate to severe workout versus when I've eaten before and done a...
You feel more energetic with fasting or less energetic with fasting?
I would say less, just, given the type of workout, dependent upon what I'm doing.
Sure.
If I'm going on a run, then, fasting, I seem to feel a little bit better than, if I'm going to lift weight. Yeah,
it's interesting. Again, in my vast experience with people like yourself and asking these questions, I'm not sure there's anything that's a formula for any individual. It's just a little bit trial and error what works best for you.
Gotcha.
So let's move on to the rest of these numbers. And some of these are less related to vascular disease. I'm going to kind of skip over those. But the next one on your page is actually homocysteine, which is one of these super interesting concepts that people talk about. And homocysteine is an amino acid. It's in the protein class. And we know that people that had higher levels of homocysteine have a relationship with higher incidence of cardiovascular disease. But there's not that much talk about homocysteine for the reason that we don't have as much data that intervening makes a difference. So the reason we talk so much about LDL cholesterol is that the association with higher LDL cholesterol and bad cardiovascular outcomes is strong, but not super strong. There are a lot of people that have high LDLs that live completely normal lives, don't get atherosclerosis, and other people that have lower LDLs that have tons of atherosclerosis. So there's a correlation, but not a perfect one.
Right.
But what we do know is that lowering LDL with treatment makes a huge difference. And time again in studies, we show that lowering LDL makes a difference, particularly when you're at high risk. But something like homocysteine that also has that relationship with bad outcomes when it gets higher has never been shown to be the same in terms of the lowering it. Plus, the neat thing about homocysteine is that it's something that reflects B vitamin metabolism. And there's a relatively easy way to treat high levels of homocysteine, which is with B complex vitamins.
Okay.
And a lot of people take multivitamins or B complex vitamins, and that will have the maximal effect on lowering homocysteine. So outside of using B complex vitamins, there's not a whole lot out there to show us that lowering homocysteine is going to make a difference, even for somebody like you with a family history.
Okay.
But that covers that. And then you have some of these things. These are things that an endocrinologist might look at. You have the zinc level, which is kind of interesting. So the general sense is that zinc is protective. Some people call it an antioxidant. And your levels are 105, which is completely normal. But this comes up a lot. And there's also something called the zinc-copper ratio. You want your zinc-copper ratio to be higher rather than lower. Copper is complex in terms of how it's correlated with cardiovascular disease. Both low levels and high levels are not good. But there's a general sense that your zinc-copper ratio should be favorable. And one of the interesting places where that was looked at was actually in the country of Finland. Finland historically had a very high rate of cardiovascular disease. And it turned out in particular that there were areas in Finland where there was more copper versus zinc in the drinking water that had the highest rates of cardiovascular disease. So some of the epidemiological insights came from that particular study looking at a country and how different parts of the country were affected in terms of epidemiological rates of cardiovascular disease. Now, again, do you recommend zinc supplements? No, unless you have profoundly low levels. And nor would I recommend copper supplements. But it's something that if you're really out of whack one way or another, you want to talk to a physician about, probably an endocrinologist.
Are you getting those already in your multivitamin that, you know?
Yeah,
that
honestly, I personally do not routinely check this in my patients.
Okay.
But it's an interesting thing from an epidemiological standpoint. And if you have a good diet and you take multivitamin once a day, you're probably doing what you need to do for dealing with these issues. And then I'll skip some of these others because they're a little esoteric. And but I'll just mention for Intrastake is that they measured your leptin. Are you familiar with that?
Not at all.
Okay. So leptin is actually something that suppresses your appetite.
Oh, wow.
And there's a lot of research going right now with the GLP-1 agonists about how it affects leptin levels and other things. And there's a belief, and we are actually doing a lot of research on this particular area, that maybe we can use changes in leptin levels to reduce somebody's appetite. So they did check that. Yours is within a reasonable normal range for what you expect for a 35-year-old man. So nothing to worry about there, but it's just interesting that that was checked. Then you had some tests of what we call inflammation. Your rheumatoid factor was negative. Your anti-nuclear antibody screen was positive, though. And this is a non-specific test that can be associated with some immune diseases like lupus. And generally, this is something your physician should follow up on and do some further testing to see if you have other elements of inflammation. Now, some of that testing was done, but not all of it as we go into subsequent things. But that's something that's reasonable to follow up because we know, for example, that patients who have lupus have higher rates of cardiovascular disease. And maybe that's the thread in your family history. Maybe that's what was something that affected your dad. And so I would definitely follow up on the positive anti-nuclear antibody test. And we'd get other types of testing to see if you have the diagnosis of lupus, although you haven't mentioned any symptoms that would make me think of it.
Right. I was going to say, what would be a
arthritic type symptoms are typical, rashes are typical. And there's other things. But again, that's a little thread. But it's also a very non-specific test. So just because it was, quote, positive doesn't mean that you have any illness related to it.
Got it.
But they did order that, and it is of interest. And I'm going to skip some of these other things in the interest of time. But I want to get to one other thing that I noticed that was super interesting, which was your LPA level. And let's see if I can find it here. So yeah, here we go. So you have what's called an advanced lipid profile. So the first thing we talked about was the standard lipid profile. But there are a lot of other ways you can look at your lipids, your lipoproteins, to get insights. So one of the things that we do in the advanced lipid profile is actually look at the number of particles. So when you measure something like LDL, low density lipoprotein, you can look at it in two ways. You can look at it based on the mass or the weight, or you can look at it in the number of particles, which we call concentration. And so when you think about it, if you have fewer particles that are of heavier weight, that's going to be a little bit different profile than people that have more particles of a lighter weight.
Right.
So in the extremes, people that have more particles with a lighter weight may have the same overall lipid levels as somebody that have fewer particles at a heavier weight, but their prognosis is different. So if you have more particles that are small particles, that's actually worse than somebody that has fewer particles that are big, more buoyant particles. And you do, in fact, have an excess number of LDL particles. So that's something we don't like to see. And you have above what you would want to see in terms of small LDL and medium LDL. So I would point out the fact that when you look at this statistically, that's another small reason why you would want to consider getting that LDL level down, or maybe even ultimately using a statin drug, which we'll talk about in a second.
Okay.
So I think that's something that's important. And then they looked at your omega check, they called it, which was looking at a panel of your omega-3 fatty acids, and that came in a little bit low. I think this is a proprietary assay, and we'll show this on the screen, but it goes into all multiple different omega-3 fatty acids, which are very important in terms of number of cellular functions. But the thing about the omega-3 fatty acids that's tricky and even difficult for physicians is that the interventional studies for some of these things have been a little bit all over the place, quite frankly. So what we know is that when you supplement with omega-3 fatty acids, you may have some benefits. There's some information, for example, that it may help mood disorders. It may help people with depression. But when we've used it to look at reducing cardiovascular disease, or particularly cardiovascular outcomes, it's been a little bit of a mixed bag. Some studies have shown positive results. Other studies have shown not great results. And so because of that, we don't necessarily focus on that. But it's interesting that's part of your panel. The flip side is that this is another one of those things that may be relatively easy to take care of. So in somebody like you, we talked about the fact that you don't eat that much fish, which is rich in omega-3 fatty acids. And you may want to consider that. So an easy intervention would be for you to just eat more fish and replace some of the other proteins with that. And I imagine that that would help your omega-3s go up. But there are supplements out there. So
yeah, I've started to supplement with salmon oil and cod liver oil. So
well, there you go.
We'll rerun these numbers in 6 months and see.
And you'll probably see them higher. But again, this is one of those reflections of how your diet can change the numbers. But you have to be a little bit careful, because I can't really tell you that the diet's going to change your outcomes. But nonetheless, there's no downside, especially if you like fish, or if it's no big deal to take a fish oil capsule a day. There's really not any significant risk to that. Sometimes people talk about the mercury risk of some of these things,
which they test for already, and that was fine, right? So
exactly. And there are products out there that are refined products that don't have mercury in it. But quite frankly, a fish oil capsule a day, 1,000 milligrams or 1 gram, I don't think is going to hurt you from a mercury standpoint. But interesting that they did that. So I want to touch on your lipoprotein a. We alluded to that earlier, and that's that really, 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 really bad cholesterol, as I mentioned. And your level here is 151. That's the concentration. It's in nanomoles per liter. And that's high. And that's super interesting, because high LPA levels run in families. And maybe that's what affected your dad.
Triggered this.
Yeah. And you mentioned you didn't have any other family members, but have you had other family members have their LPA checked? Do you know of?
I'm sure they have.
Brothers, sisters, or your mom, or I'm
sure my mother has. My wife has, but I haven't asked about it.
Or anybody on your dad's side of the family, aunts or uncles on his side of the family?
Yeah, not that I've asked.
The reason I ask that is because there's a genetic inheritance pattern for lipoprotein A. It's called, we would call autosomal dominant. And that number is really determined by your genes.
Okay.
So your overall LDL, as I mentioned, is a combination of your genetic predisposition and your diet, but LPA is almost all genetics. And it's interesting for somebody like you that has an LPA level that's elevated to see what their genetics are. And you can kind of figure it out because you got one or both genes from your parents, and it's discernible once you can figure that out. Obviously, your father's deceased, so we can't get that now. But by looking at other of his family members, you may be able to figure that out.
Or just his history. If my mom doesn't have it, then he would have had to have it.
Exactly.
Correct?
That's right. So the deduction.
Right.
Deductive reasoning. Yeah,
Right.
that's right.
And I guess to that point, for my kids' sake, since I have it, and if my wife had it, they all by trait will have it. Is that a safe assumption?
Probably so, but not necessarily. Because
okay.
remember, an autosomal dominant gene is something that hides a recessive gene. So let's say that they both got recessive genes that don't code for LPA at high levels, then they would have normal LPAs.
Got it.
I probably confused you with that, but
no, I can understand.
Just like two brown-eyed people can have a blue-eyed baby.
Right. Makes sense.
Right. So anyhow, but your lipoprotein A is high, and so that is something that would be a risk factor. And as I mentioned, that's actually a stronger risk factor than LDL itself. So because of that, you would be somebody that I would want to explore a little bit more where you stand in terms of atherosclerosis.
Okay.
And I'll get to that in a second. The flip side is that you also got what's called an hs-CRP, which is a look at your vascular inflammation, and that was beautiful at 0.2.
Great.
Okay? So generally we want that to be less than 1, and yours is optimal at less than 1. And there's some data that's showing of all these markers, we call these biomarkers, of all these biomarkers, the hs-CRP may be the one that's most highly correlated with bad cardiovascular outcomes in the future. There's some debate whether or not LPA or hs-CRP are better. My personal opinion is that LPA identifies certain subgroups that are particularly high risk.
Okay.
And hs-CRP is more of a general sense of vascular inflammation. But nonetheless, it's good news that your CRP is low. And that's becoming more and more studied in terms of how inflammation and the identification of inflammation leads to bad cardiovascular outcomes. And we've had some podcasts on that. So if you like this discussion, I invite you to look at some of the other podcasts we do. In particular, I did a podcast with my classmate, Dr. Paul Ritker, who's considered the international guru on CRP and inflammation, and you'll learn a lot more about this.
Love it.
But yours is good, so that's good.
Great.
All right. So we covered a lot of ground here. Any questions before I get into maybe some recommendations?
Yeah, I guess, one thing that I've done within the last 2 years, just before getting all of this done, and curious to see what your thoughts are. You mentioned Finland earlier in the podcast, and I have a sauna in my backyard.
Okay.
And, in the fitness side of things, it's obviously very common to do and becoming more and more common nowadays, or more accessible. And just curious to get your intake on, sauna usage and higher temperatures for an extended period of time.
So there's a lot of these things we just don't know the answer to.
Right.
So when we do look at things scientifically, we have to do a randomized trial. And a randomized trial means that we randomly choose you to one thing or another. So a randomized trial of sauna use would be to randomly put people in saunas or to do something else and compare the results over a period of time or based on a biomarker or based on something. So we just don't have those kind of studies for sauna. But if it makes you feel good, there's not a whole lot of downside. Just be careful because it can lower your blood pressure. And if you get out too quickly, you can hit your head and do some damage that way. Yeah. But I certainly, there's some things in life that you should just enjoy. And sauna is one of those things. But to have to do it compulsively for your health, I don't necessarily don't need to recommend that. Okay. But I don't see anything wrong with it either.
Good to know.
So this gets into some of the things that what we would do is if you were in a patient setting with me, what we do in terms of our plan, how we're going to move forward with all this information. We've got a ton of information. We cover a lot of stuff. So what do you do next? Well, obviously, you're very concerned with your risk, and you have some factors here that will need to be followed up, like your ANA, and we talked about your LDL and your LPA. But what do you do to look at your risk? And one of the things that I would recommend for you is what we call a coronary artery calcium score, or CAC score. And what we're learning is that CAC score gives you good insight into whether or not you're prone to atherosclerosis. And if you remember, we first became more aware that young people can have pretty bad atherosclerosis based on autopsy studies that were done during the Vietnam War. And these were young men, 18 to 24-year-old men that were killed in battle, unfortunately. And during the autopsies, it showed that some of them were already developing atherosclerosis in their aorta. Wow. And as technology has progressed, we can now determine whether or not you have atherosclerosis without doing an autopsy, fortunately. Sure. And the easiest way of doing that, and it's a cheap, effective way, is looking at the amount of calcium in your coronary arteries.
Okay.
And calcium is the way our bodies heal atherosclerosis. So if you have some atherosclerosis that develops, your body's going to try to heal that, and it'll typically will calcify that plaque, and that'll show up in a CAT scan. CAT scanning is a very good way of looking at calcium. And so somebody like you at age 35, you would hopefully have a 0 CAC score. You wouldn't have any calcium. So if you had a 0 CAC score, I'd feel a lot better about using diet and exercise to try to continue to work on that LDL. But if you had a CAC score that was above 0, any number above 0, I would say, at your age, Tucker, this means that your body is starting to already develop some atherosclerosis, and I would actually recommend a statin for you. Now, the reason I wouldn't recommend it without the CAC score is that we probably wouldn't make a difference in the next 10 years if you had a 0 CAC score. But if you had any positive CAC score, then I think the statin would. And statins are one of these drugs that unfortunately have a mixed reputation, even though they should be like the mother's milk of cardiology and treating people. Because unlike some of these other things I mentioned, every time we study statins, we get a positive outcome. So lowering the LDL with statins has uniformly led to better outcomes. But of course, that's dependent upon your risk. So if you're 35 years old and you have virtually no risk of having an event for the next 10 years, will statins make a difference? No, they won't make a difference because there's nothing to prevent. On the other hand, if you're 60 and you have the same profile, then they're much more likely to actually make a difference. So if I saw these numbers in somebody age 60 with everybody else the same, I'd absolutely put them on a statin.
And what's the scaling range for CAC scores, I guess? Is it
0 to over thousands?
Okay.
Yeah. So again, it's very age dependent.
I was going to say, so a person in their 60s probably definitely has they're not at 0.
That's right. Most people, it would be relatively unusual for somebody in their 60s to have 0, but some do.
Wow. And
some people in their 70s have 0. So I've had actually many patients that come to me freaking out about their LPA. And they'll have the same LPA as you. They'll be 72 years old. I'll do a CAC score and it's 0. Wow. And I have the great pleasure to tell them, well, nothing's perfect in medicine, but your risk is really super low. Wow. So I wouldn't worry too much about your LPA. Thank God there's something that's protecting you. And we may not even understand what's protecting you. Hopefully in the future we will. Right. But despite the fact that your LPA is high, I wouldn't freak out about it. Good. On the other hand, we have people who are in a similar situation that are zealots in diet and exercise, and they have CAC score in the thousands. They'll say, Doc, I'm doing everything. I eat a vegetarian diet. I run 50 miles a week. Why do I have a CAC score of 1,000? Well, as we know from a number of very high-profile people that have died despite their fitness, there's stuff that can happen that we can't control.
Right.
And that's where you need medicine.
Right.
So yeah, the CAC score is something I would recommend in you.
Okay.
And then we look at that and we see, okay, are you somebody that can continue doing diet and exercise to treat these issues, or you're somebody that I would start a statin on? And I would look at that as a determining factor in somebody like you.
Good to know.
Yeah.
Excellent.
And then the other thing that came up is we kind of covered it already. Should you take some supplements? Doesn't hurt to take some fish oils, but you would accomplish pretty much the same thing by eating more fish.
Right.
But again, nothing wrong with an insurance policy as long as you don't mind burping up fish every once in a while.
Yeah.
The secret there is keep the capsules in the freezer, and they tend to slide down better.
Good to know.
Yeah.
All right.
And they tend to, in my experience, cause less burping. And
good to know.
Sometimes it could be a little embarrassing in a meeting if you smell like salmon.
Yeah. You're the last person in the office that anybody wants to be around.
Right. But I don't see any harm in that. And in a multivitamin, especially multivitamin with vitamin B complex vitamins in it is certainly something that I seem to do little harm.
Okay.
But then some of these other things that are out there, I would talk to a doctor before you do them,
Sure.
because I have a lot of patients come in and they're on a list of 15 supplements that they were told were, quote, good for them,
Right.
but they don't necessarily have a good reason for them.
Right.
And unfortunately, supplements can do bad things, especially if you take too much of them. So I'll give you a personal example. When I finished my cardiology training over 30 years ago, I recommended vitamin E based on epidemiological data showing that there seemed to be a correlation with vitamin E and its antioxidant effects and better outcomes. But then there were interventional studies were done where you actually randomized people to vitamin E or not. And 3 major interventional studies were done, and 2 of the 3 actually showed a tendency towards harm of vitamin E supplements.
Wow.
So you never know until you do the testing
Right.
what these things are going to look like. And because of the fact that supplements are not supported by pharmaceutical companies and they're just sort of considered part of your diet, they're not tested to the same degree as things that are pharmaceuticals, which go through incredible testing. The scrutiny around those pharmaceuticals is intense. And as consumers, people can benefit from that knowledge by either participating in clinical trials or by reading the results.
Right.
So in your case, certainly I see no harm in a fish oil supplement. I wouldn't necessarily recommend more than 1,000 milligrams a day,
Right.
and a multivitamin with B complex in it. But other than that, I'm not sure there's anything else that would jump to the fore.
Cool. Yeah, we'll keep the regularly scheduled program with and my kids don't eat fish, right? You can make it, put it in front of them, they won't touch it. So that's more or less why
you can disguise tuna in different ways.
Right, that's a good point. They will eat raw tuna, but any salmon or anything like that, it's a different story.
Well,
so
if it looks like a fish, they won't eat it.
right, exactly right. No.
Well, in any event, do you have any other questions?
No, obviously a lot to unpack, and I appreciate you taking the time to review this, and I'll have a follow up in another couple months just to see where I am now. I'd love to get the CAC and really see where I am in that.
Let's do that for our audience.
Okay.
So we'll get your CAC score.
Yeah.
And we'll have you come back after some of maybe these dietary interventions and even your sauna, and you can tell us how you're doing with that.
Yeah.
And we'll see how the numbers look.
Yeah, I would love that. I would love that. Thanks for having me.
Tucker, thank you for being part of MedEvidence.
Yeah, appreciate it. Thank you.
Thanks for joining the MedEvidence podcast. To learn more, head over to MedEvidence.com or subscribe to our podcast on your favorite podcast platform.